Hello, I'm Dr. Nevena Damjanov. I'm the Chief of GI Oncology at the Penn Presbyterian Medical Center with the Abramson Cancer Center of the University of Pennsylvania. In this video, I will be presenting equitable access to quality care for unresectable hepatocellular carcinoma. I will start with a patient case. This is a 53-year-old man with chronic hepatitis C virus infection. A liver biopsy performed 10 years ago revealed only mild fibrosis. At the time of presentation, his albumin was 2.9, a total bilirubin of 1.1, a platelet count of 86,000, and an INR of 1.1. At the time of presentation, his EGD showed only small varices, and his calculated Child-Pugh score was A with a MELD score of 7. His alpha-fetoprotein was 581. An MRI of the liver was performed, and this showed a 1.4 by 1.4 centimeter exophytic lesion on the left lateral lobe, as you can see here. This led to some management questions in the liver tumor board. What are the patient's treatment options? Would the surgeons operate on this patient with Child-Pugh A cirrhosis? And should this patient be evaluated for a liver transplant? Following a multidisciplinary discussion, the patient was evaluated and listed for liver transplantation. He then underwent resection of this lesion, given its exophytic nature. The pathology report showed a hepatocellular carcinoma, 1.3 centimeters in greatest diameter, moderately differentiated with no lymphovascular invasion identified. The resection margins were free of tumor, with a 0.8 centimeter margin from tumor to resection margin. In addition, the pathologist reported chronic hepatitis with cirrhosis. So what is the prognosis for hepatocellular carcinoma? 4 features have been recognized as being important determinants of survival: the severity of underlying liver disease, the size of the tumor, the extension of the tumor into adjacent structures, and presence or absence of metastases. In terms of staging, the 4 most commonly used systems are the TNM, or Tumor Node Metastases System of the American Joint Committee on Cancer, the Akuda, or Japanese system, the Barcelona system, and the CLIP score. There are several independent prognostic factors for overall survival in patients with advanced hepatocellular carcinoma. Significantly, if there's more than 1 liver lesion, that's a poor prognostic indicator, as is bilobar disease. The presence of abdominal pain is a worse prognostic indicator, as well as the presence of esophageal varices and a poor performance status. More advanced Child-Pugh stage, as well as abnormal liver function tests, are also poor prognostic factors. Survival in HCC influenced by additional several factors listed here. Again, severity of underlying liver disease, the histologic grade of differentiation of the HCC. A higher level of alpha-fetoprotein at diagnosis is a worse prognostic indicator, extent of disease spread, and whether patients are living in high incidence versus low incidence areas. Here is the Child-Pugh score for grading liver disease. As a reminder, this is an indicator of the likelihood of surviving 1 and 2 years due to the underlying chronic liver disease. If a patient has Child-Pugh A liver disease, the chance of surviving 1 year is 100%, while if a patient has a Child-Pugh C liver disease, the 2-year survival from the liver disease is down to 35%. The MELD system is used by the United Network for Organ Sharing, or UNOS, in prioritizing allocation of deceased donor organs for liver transplantation. and it is calculating according to this following formula. You will see this used in most liver transplant centers to assess the severity of the underlying liver disease. Back to our case. 10 months after resection, 2 new lesions are noted in the right lobe of the liver, 1.0 by 1.6 centimeters and one that was less than 1 centimeter. Both of them were consistent with HCC. These were not seen prior to resection. At this time, the alpha-fetoprotein was up to 86. The patient underwent transarterial chemoembolization twice, with the after-taste MRI showing a partial response to the second right-sided chemoembolization of the right hepatic lobe lesions, with a decrease in size and increasing necrosis of the anterior lesion, and decrease in size but persistent enhancement of the second lesion. The alpha-fetoprotein had risen to 306. At this time, the patient is listed for transplant with MELD exception points. So what are the data for post-treatment surveillance? No data exists to guide post-treatment surveillance in patients after local regional therapy for hepatocellular carcinoma. Consensus-based guidelines from NCCN suggest the following after ablation or resection for HCC. Imaging every 3 to 6 months for 2 years, then every 6 to 12 months if the size of the lesions is unchanged, and the assay of alpha-fetoprotein, if initially elevated, every 3 months for 2 years, then every 6 to 12 months. Back to our case. Our patient developed widely disseminated progressive disease despite aggressive local regional therapy. He developed metastases in the lungs and bones. A week after his restaging MRI, he developed an episode of hematemesis, and an EGD confirmed esophageal and gastric varices. The esophageal varices were easily mended, however, the gastric varices were unable to be treated. His liver function remained good, with a Child-Pugh score of A5. Despite the presence of widely metastatic disease, the patient remained interested in pursuing life-extending treatment. As I noted previously, extensive extrahepatic disease was identified, and additional liver-directed therapy was not felt to be in the patient's best medical interest. He did not have any contraindications to receiving immunotherapy, such as uncontrolled autoimmune disease or previous organ transplantation. Immunotherapeutic options were reviewed with the patient with the goal of maximizing benefit while minimizing potential adverse events. There are several recommendations for systemic therapy listed in the NCCN guidelines. The first-line systemic therapy preferred regimens are atezolizumab and bevacizumab, as well as tremelimumab and durvalumab. We expect that ipilimumab and nivolumab will be added in the near future. Other recommended regimens include single-agent durvalumab, single-agent lenvatinib, sorafenib, and other single-agent immunotherapies. In certain circumstances, specifically for NTRK gene fusion-positive tumors, repotrectinib is an option as well. This is one of the reasons why a liver tumor biopsy is recommended. For this patient, considerations for systemic treatment need to take into account that the patient had a recent life-threatening bleed. Therefore, an antivascular endothelial growth factor therapy was not felt to be safe. In the IMbrave 150 study of atezolizumab and bevacizumab, exclusion criteria included patients with untreated or incompletely treated varices with bleeding or high risk of bleeding. In the IMbrave 150 study, patient must have had an esophagogastroduodenoscopy, and all size of varices, small to large, had to be assessed and treated per local standard of care prior to enrollment in the study. Those patients who had an EGD within 6 months of initiation of study treatment did not need to repeat the procedure. In our patient, through shared decision-making, the patient and his treatment team agreed to initiate palliative systemic therapy with durvalumab and tremelimumab, which did not include an anti-VEGF treatment. What are the data for durvalumab and tremelimumab for unresectable hepatocellular carcinoma? The STRIDE, which stands for single tremelimumab regular interval durvalumab regimen, is a single high priming dose of tremelimumab and anti-CTLA-4 plus durvalumab and anti-PD-L1. They were found to improve overall survival compared to sorafenib in patients with unresectable hepatocellular carcinoma. In detail, the median overall survival was 16.43 months with STRIDE regimen, 16.56 with the durvalumab regimen, and 13.77 months with sorafenib. Grade 3/4 treatment emergent adverse events occurred in 50.5% of patients receiving STRIDE. The immune-mediated events leading to treatment with high-dose glucocorticoids occurred in 78 patients, which is 20.1%. The most common immune-mediated events were hepatic events, diarrhea, colitis, and a dermatitis or rash. The STRIDE regimen is administered every 4 weeks, and the less frequent dosing than other first-line parenteral regimen treatment options, as well as no concern for daily treatment compliance, unlike what is reported with oral medications, are reason to consider it. Back to our case. After the first dose of treatment, the patient developed diarrhea. Specifically, had an increase of 5 stools per day or grade 2 diarrhea. The diarrhea did not respond to doloperamide and Lomotil. The median time to onset of GI toxicities is 6 weeks in our studies, with a wide range of 1 to 107.5 weeks. He was started on prednisone 1 milligram per kilogram orally until his diarrhea improved to 3 stools per day or grade 1. The prednisone was slowly tapered over 4 weeks. Had this not responded to prednisone, infliximab or vedolizumab may be administered for refractory cases or if symptoms do not improve within 2 to 3 days. Tofacitinib and ustekinumab are second-line options. Budesonide lacks supporting evidence for efficacy, though you will see it used for patients with intractable diarrhea from immunotherapy. The patient restarted the durvalumab without a recurrence of his diarrhea. Up to a third of patients develop a recurrence of diarrhea upon rechallenge with immunotherapy. Fortunately, our patient did not. A CT scan following dose 12, so about a year into treatment, revealed slight tumor growth. The patient's end organ function remained unchanged without a recurrence of any immune-related adverse events. A second dose of tremelimumab was administered in hopes of regaining tumor control. In the Himalaya study protocol, if there was evidence of progressive disease during the durvalumab monotherapy portion of the regimen, the patient could be rechallenged with tremelimumab once. Treatment will be continued until there is evidence of disease progression. The patient at this time is doing well. Thank you for watching. We would like to thank our partners, the Global Liver Institute and Blue Fairy, as well as our project sponsor, AstraZeneca. Thank you for watching with the Association of Cancer Care Centers.